Thank you, Dr. Sung. Let me just pull my slides up here. Okay, well, I'm excited to be with all of you today and to be part of this issue of Hepatoma Research, and I thank Dr. Sung for the invitation. I'm going to share with you a little bit about my thoughts on resection of BCLC stage B HCC, the so-called aggressive HCC, and some of the work that we've done on this in our group. So this group obviously needs no introduction to the HCC and its incidence, how common it is, how many deaths it causes worldwide. And as surgeons, we resect these tumors and we use a number of various different staging algorithms. Probably most commonly, we use the American Joint Committee on Cancer, TNM staging manual. But many of us also use CLIP, BCLC, JIS. And what is interesting is that with the BCLC, not only is this endorsed by both EASLD and AASLD as a prognostic schema, but also as a treatment algorithm. So what's unique about BCLC compared to AJCC or some of the other staging systems such as CLIP or JIS is not only does it incorporate such factors as tumor status, but it also incorporates liver function, Child-Pugh class, and then also the patient's underlying performance status, ECOG status, and then puts all of these data together into a prognostic scheme, but then also, as I mentioned, as a treatment allocation algorithm. And whenever you create a treatment algorithm for a disease as complex as hepatocellular carcinoma, you're going to have controversy. And that's what we have with the BCLC, is that there's lots of controversy about whether this algorithm is accurate with regards to its treatment recommendations and whether it should be followed in the clinical setting at all times. And as you can see here, very early stage disease, so-called 0 stage disease, are those patients who have truly early stage, small tumors less than 2 centimeters, have good underlying liver function and also have good performance status. BCLC-A, tumors a little bit larger. Now you'll have multifocal disease, but still a good performance status. But then this intermediate stage, a so-called multifocal disease. These are patients who are controversial, whether we should be operating on them, whether we should be sending them down more non-surgical pathways such as chemoembolization, or should we be resecting them? As I mentioned, resection is kind of a universally accepted, or transplant or some other curative paradigm for patients with very early stage BCLC-0, BCLC-A, but there's lots of controversy around BCLC-B and whether resection would be justified in these patients. Now, many papers have been published on this topic. You can see a paper that we published in Annals of Surg-Onc, I guess earlier this year, but other centers, both, and you can see here in Italy, and also in Asia, Japan, China, Korea, and other places have published on this topic. And if you look at a meta-analysis on these data, you can see here in this plot that many studies show a favoring for partial hepatectomy. So you can see favors pH, favors partial hepatectomy versus TACE in patients who have BCLC-B. And then if you look over here on the right, again, you can see that in patients who have BCLC-B, that there may be a subset of patients who indeed could benefit from partial hepatectomy rather than what most of us would consider other non-curative algorithms or paradigms such as TACE. And in this bubble plot, you can see that in some patients who have BCLC-B, when you compare partial hepatectomy versus TACE, that there seems to be a survival advantage both in the short term at 1 year, but a persistent survival advantage that seems to last even 5 years after resection. Now, obviously, these data are problematic and controversial. Probably the biggest problem is that these are retrospective data. There are also many inconsistencies in the inclusion and exclusion criteria, and also within the definition of the BCLC stage with regards to tumor size and multifocality. So there's overlapping of populations. And then also some of these studies have involved patients who've had sequential treatment. So patients who maybe had TACE and then went on to resection or had resection, and then even in some Asian countries, as was alluded to by Dr. Brown, use adjuvant TACE still. So our group looked at this. This is that paper that we published. Actually, it's a different paper that was published 2 years ago in Annals of Surgery. And we looked at our international multi-center cohort of patients with HCC. We have about 800 patients in this database. And you can see here schematically in the right upper hand corner is what the different BCLC staging classifications look like with regards to number and size of tumors in the liver. And not surprisingly, we showed that there is a clear incremental worsening of 5-year survival as one moves from BCLC-0 to A to A1. Perhaps a little bit more surprisingly is panel B, is the Kaplan-Meier curve suggesting that there are some patients who have BCLC-B, which are tumors greater than 3 centimeters that are multifocal, that they have a similar outcome than patients who have BCLC-A1, which is a solitary lesion that is 5 centimeters or greater. So again, suggesting that perhaps there is a subset of patients who have a more aggressive BCLC-B who may benefit from long-term survival from surgery. And these data that we published using largely European and data from the United States were confirmed in this data set from Japan, which similarly showed that in patients who had multinodular disease, BCLC-B, that 5-year survival could be as high as 45%, albeit the disease-free survival was only 22%. So while 44% of patients were alive at years, over 80% occurred. This is a separate study that was published in Korea that used a propensity matched analysis to look at patients who underwent resection versus no surgery. And again, these authors noted that in well-selected patients that indeed surgery may be associated with a benefit for BCLC-B patients, as patients in this study had a 5-year survival that was very high of over 65%. Now, this is a paper that we published in Surgery looking at the potential for cure, because as I mentioned in that Japanese study, even though patients were alive at 5 years, many of them had recurred. So we looked at a true kind of cure, if you will, at longer time points at 5 years and 10-year survival. And what we found is that patients who underwent resection of HCC, the overall 5-year survival was about 65%, and the cure fraction was lower at about 40%. And what we noticed was, again, perhaps not surprisingly, that the cure fraction among patients who had BCLC-0 or A was about 50%, but the cure fraction in BCLC-B patients was lower, but still, reasonable at about 35%. Furthermore, when we looked at the overall pattern of recurrence of patients who were either within or beyond BCLC-B criteria for resection, so in other words, patients who are beyond BCLC-B A, that the overall patterns of recurrence were relatively similar, with the overwhelming majority of patients recurring in the intrahepatic space, whether that be early recurrences or late recurrences. And again, only about 10% of patients developing an extrahepatic recurrence. On multivariate analysis, what we found was that the only factor that was significantly associated with long-term survival in BCLC-B patients was AFP level. Patients who had an AFP level of greater than 400 were markedly higher at risk of developing a recurrence and dying from disease. Other groups have tried to further substratify the BCLC-B stage B patients to figure out whether we can identify a subset of patients within this kind of middle aggressive tumor type to resect. And in this patient from the Japanese group, we see that they divided the BCLC-B patients into 3 different subtypes. based on tumor size and different number. And we're able to identify patients who had type 1 who had better long-term outcomes. Similarly, in our paper, we noted that patients who were within BCLC and beyond BCLC-B had different long-term outcomes. And you can see here that both a recurrence-free survival and a disease-free survival, overall survival was lower in people who were resected who had disease beyond the BCLC criteria. And then down below, you can also see that this up to 7 rule also was able to stratify patients with regards to long-term outcomes. More recently, our group has focused on this concept of tumor burden score. And what the tumor burden score is, it is a single metric trying to assess the overall burden of disease in the liver. So when you think of burden of disease in the liver, it's how many tumors you have and how big those tumors are, trying to assess the overall burden. And by using the Pythagorean equation, we were able to come up with a simple single composite score to assess the overall tumor burden in the liver. And you see here, again, perhaps not surprisingly, is that people who are BCLC-0 have a low tumor burden score. Patients who have stage A have a wider spread. And then in stage B, while the majority of patients have a medium score, some have a high score. So there is some dispersion in difference in heterogeneity in the tumor burden in patients who have stage A and stage B. And perhaps we can take advantage of this tumor burden score to identify patients who will benefit the most from surgical resection. And indeed, if you look, when you take patients, they can be stratified very accurately using the tumor burden score with regards to both overall survival and disease-free survival. And if you look, when we stratified patients based on BCLC-A versus B, we could identify that there again was a survival difference, but that using the tumor burden score, we could substratify patients who were BCLC-A versus B into different prognostic groups. And therefore, we would advocate for the combination of the BCLC staging with tumor burden score, because as you can see here, you can identify patients who are BCLC-A who have a high tumor burden score, who actually have a worse survival than patients who are BCLC-B with a medium tumor burden score. So we think that in addition to using the BCLC algorithm, that the adoption and integration of tumor burden score may be able to further substratify patients. And indeed, in this recent paper in Annals of Surgery, we showed that indeed the two most important factors were preoperative AFP and tumor burden score. And in using these two factors, you could identify a subset of patients with a so-called aggressive HCC multinodular disease who had a significantly better long-term survival. And you can see in using this preoperative score that combined AFP and tumor burden score, patients who were low risk actually had quite a good overall survival. And this score was actually externally validated in a separate data set of patients with intermediate HCC and proved to be quite accurate. And you can see here also with regards to risk of overall recurrence, those patients with a low risk were markedly lower likelihood to experience recurrence. And then finally, I'll just touch on some of our even more recent work that we've been doing with artificial intelligence and machine learning to help us better identify candidates for resection beyond the BCLC criteria. Many of you may be familiar with machine learning and artificial intelligence. This is a mechanism by which one can use large data sets and algorithms to help you identify different nodal points and or decision tree factors without the input of human bias. And essentially by creating these algorithms and having them run on our data sets, what we found that using only preoperative factors, only those factors that are available preoperatively, interestingly, people who are BCLC-0 or A, the factors that were most important in driving their survival were AFP level and overall patient performance status, like Charleston comorbidity, ECOG status. However, people who had BCLC-B disease, what we found was the most important factor driving their long-term survival was indeed a radiographic preoperative tumor burden score, confirming our previous publications. And indeed, when you looked at the postoperative model, this held up. There were some slight changes in that in BCLC-A and 0, lymphovascular invasion, which obviously cannot be identified preoperatively, but can be identified on the pathologic specimen, became an important factor. But pathologic tumor burden score remained an important factor in identifying and stratifying patients with intermediate HCC. So I'll end where I began, which is at the algorithm for BCLC. And I would just suggest that this intermediate stage group of patients is not homogeneous, that it is a complex group of patients that warrants discrimination and consideration for resection, that one should not a priori dismiss these patients from surgical resection, but based on our data and others, we would suggest that you use the AFP level as well as the overall tumor burden score to help identify which patients may benefit the most from resection. And perhaps some of our data and suggestions could be used to further refine and subclassify patients within the BCLC staging schema in the future. So with that, I'll conclude. And again, I'd like to thank Hepatoma Research and Dr. Sung for the opportunity to present. And I look forward to discussion and questions later this morning. Thank you.